to get into another bit. Just so some cases. So again, this is a very sick child with asthma whose picture I've stolen off the internet, so I'm sorry if you're watching. Case 1, 10-year-old boy referred with daily cough. So I think the first thought here should be this is probably not asthma if you're seeing someone for daily cough. But it was worse in cold air or with a cold. No wheeze, history of hay fever, family history of some weird CF problems. But his spirometry had a mild obstructive pattern. So what would you do next?
Do a sweat test.
Yep. Anything else? Yep. He's actually really well. So asthma is very common, and so unusually I started him on asthma treatment and he responded. And also the objective testing responded. But the important message here is, so with high likelihood cases, you should just assume it's asthma and start treatment. With low likelihood cases, you should assume it's not asthma and do diagnostic testing. With medium likelihood cases, you should try some treatment and review. And if they don't respond, then you should do the diagnostic testing. But in this case, he did respond, so I thought it was asthma. But I think particular caution needs to be taken with chronic cough, in New Zealand particularly. Case 2, 15-year-old girl, asthma since 5 years of age. She's already on Seretide, and she'd recently had 5 severe episodes, including 2 ambulance episodes from school this year. Triggers were exercise and fumes. Last trip, she had tingling in her lips, and she had carpopedal spasm. So what do we want to know next?
She got a young kid.
Her calcium level and any other autonomic symptoms of anxiety.
Yeah, so this is very suspicious for hyperventilation syndrome. So her control, she's wheezing quite regularly, so I thought she actually did have asthma. And to the point she can't participate in sports. Compliance, taking 1 dose of Seretide in the evening, but having her morning dose when she needed it. She had no normal lung function with a borderline response to bronchodilator. And when I examined, so I look at people's breathing quite a lot in clinic, and she had a suggestion of hyperventilation. So I taught her as much as I could, not being a physiotherapist. So I did what I always do in every clinic. I checked her control, I checked her compliance, I checked her inhaler technique, and I gave her an action plan. The lessons.
Tell us very briefly about the stop, drop, and flop.
So functional breathing problems are really common in asthma, kind of superimposed. So, patients with hyperventilation often have asthma as well. So they need to stop if they get short of breath, drop, which is sit down or lie down, and flop is just relax. And then I often spend a lot of time showing them the difference between what they're usually. I lie them down and they're usually breathing like this, and I just get them to do diaphragmatic breathing. Often just being aware of the issue resolves it. There's books on hyperventilation syndrome and special hyperventilation clinics, but often just one visit and making the patient aware of it's enough. But sometimes I have to refer them on. But stop, drop and plop. Stop, sit down or lie down, and then relax all your muscles. Functional disorders commonly coexist. So, sorry, the reason I wanted to emphasise this case is confusion about relievers and preventers is common. So it's, it is worth asking that question, what are you supposed to be on, before asking what are you actually taking. And always review the basics, because this was a girl being dragged into hospital, and it was really important to check her inhaler technique. Case 3, 12-year-old girl reversed after 2 episodes of respiratory arrest with asthma. So that's near death twice. One with urti, one with fumes. She had quite a convincing history of asthma, using salbutamol quite regularly, going through an inhaler of salbutamol monthly, so that's an alarm bell, that's way too much. Night waking twice per week, which, that's in those poorly controlled, but that's also, night waking is bad. That's a bad alarm bell too. And she wasn't able to exercise. No signs of chronic disease, severe obstruction, quite allergic, the high IgE, currently on Seretide, and relatively compliant. And I could look through the system and see that she was getting an inhaler at least every 2 months. It gets a bit difficult because sometimes people get samples and then they've got old ones stored up from previously, so I'm not too confrontational when I see that they're only getting it 2 months. What would you do next?
Send you a letter.
Excellent. Was listening. The first thing is this girl's way out of control, at risk of another sudden episode. So I gave her a month-long course of steroids just to get things under control. Changed the Seretide to Vanair, just because sometimes changing brand can help. And also I was vaguely anticipating using the SMART program in the future, which is not licensed with Vanair, but which is, it's only licensed with the Turbuhaler, but I don't see any reason you can't use it with Vanair. Added Montelukast, reviewed her action plan. It's become quite common for people to be prescribed 6 puffs of salbutamol every time they need it, especially if they come through hospital. If we go back to the epidemic of deaths we had in the late 80s of asthma, most of those patients were on home nebulizers. 6 puffs of salbutamol is the same dose of salbutamol as a nebulizer. So it's bad, it's too much. And as I said before, too much salbutamol can be irritant. So I tried to wean her off her salbutamol a bit. Sometimes we have to admit people to hospital and get them off salbutamol. And she had very poor perception of symptoms. She also had mouth breathing when I was looking at her, so she's really blocked up in the nose, so I treated her hay fever as well. Some improvement, but she's still always poorly controlled when I see her. So lessons from this case, one is excess salbutamol is harmful, and we need to be careful about not prescribing too much. High risks for severe exacerbation episodes are poor symptom perception, obesity, poor compliance, frequent salbutamol prescriptions, and a recent exacerbation within the last 1 to 2 years. And as we had that conversation before, a peak flow meter can be helpful for poor symptom perceivers, although I don't normally use it in children. Last case, 14-year-old girl diagnosed as asthma since 5 years of age, on Seretide, gets attacks with colds, has eczema, short of breath with sport, no relief from salbutamol, never admitted. So this doesn't go with this. And this doesn't go with this. Very low peak flow. What would you do next?
Check her inhaler technique and peak flow technique.
Yeah, so there's something funny going on here.
Get a spirogram.
Yeah, so this is her spirogram. Really, I mean, I don't know if you guys look at the shape of these much, but this is really flat. It's not normal, and it's not obstructed. It's flat. And this is her CT. She had a vascular ring compressing her trachea, so she didn't have asthma at all. But she's getting a lot of Seretide. So all that wheezes is not asthma. Review response to treatment in all patients. So, you know, you start someone on treatment, you bring them back and see if they've responded, and investigate if they're not responding. So I'm sure when she first presented, she looked like she had a high likelihood of having asthma. You know, it's only after she's been through the mill a few times that it looks like a low likelihood and there's something suspicious going on. And that's when you should investigate. I might skip discussion of the cases because what I want to do is look at inhaler technique.